Hi, I'm Vic Tapson. I'm in pulmonary critical care medicine. I see patients at Cedars-Sinai Medical Center in Los Angeles, inpatients and outpatients, mostly with pulmonary hypertension and pulmonary embolism. Well, I want to talk a little bit about health disparities that patients with PAH, pulmonary arterial hypertension, face. I think it's useful probably to define health disparities first. And so one paper by Healthy People published just last year suggested that a health disparity should be defined as a particular type of health difference that's closely linked with social, economic, or environmental disadvantage that adversely affects groups of people who have experienced greater obstacles to health care based on their racial or ethnic group, religion, social economic status, gender, age, mental health, disability, sexual orientation, a number of things like this. And these have been linked to discrimination or exclusion and clearly affect many disease states and health overall. I think it's fair to say that the COVID pandemic has put a big strain on the world that kind of highlights this health disparity that we see experienced by minorities and marginalized patients. Right now I want to focus on PAH for a few minutes though, independent of COVID, and point out that Group 1 PAH still is an orphan disease associated with underlying causes, still has poor median survival if it's untreated. It remains underdiagnosed. This is exaggerated in socioeconomic disadvantaged people. People come to the diagnosis late enough sometimes with good health care, complaining of shortness of breath. It's written off as anxiety or asthma or something like that. This happens enough. But in patients who can't get to health care because of public transportation or because of not having the money and not having daycare, not having the means to insurance, etc., clearly PAH is more under-recognized and diagnosed later. So, and it's becoming more complex. We have more medications now. PAH is a complex disease. So certainly discrepancies in health outcomes have been described in people with PAH based on race, ethnicity, gender, age, some of the things we mentioned before, socioeconomic status. And these certainly negatively impact health. So racism and discrimination is a classic one. This certainly happens, and it's been ongoing for a long time, has many negative impacts in addition to health care. There's environmental determinants that are affected by race and economic segregation. There's things like community violence that affect people. It's actually been demonstrated the physiologic stress response to community violence increases systemic inflammation, which is incredible, but true. We know that minorities are exposed to occupational hazards. Poor neighborhoods may be located closer to high traffic density, closer to pollution. We know there's issues involving things like drugs in poor socioeconomic settings. Methamphetamine causes PH, very difficult problem, very addictive problem. So there's a number of things like this that affect patients that suffer from health disparities, and we need to figure out what to do. I was excited to see a paper published a couple of years ago. It was an ATS, American Thoracic Society statement, published 2017, before COVID, and basically emphasizing some of the differences that occur in patients with PAH based on health disparities. And that they noted there were few studies really going over what the issues are and how we can help them. So I think one of the things this health statement did was come up with some bullet point messages they thought we should pay attention to based on these health disparities patients with PAH face. And one of them was to basically say that, we know that there's certain genetic predispositions to certain cardiovascular disease that are definitely influenced by race, for example. Whether this is true with PAH is less clear, but some data suggests it is influenced in PAH. But the ATS group recommended that we should focus on genetic screening and counseling in the future, and when we do this, emphasize minority, socioeconomic status, etc., things that relate to health disparity. They stated that registries in PAH have lacked detail or information on what minority group someone belongs to, what race, what their socioeconomic status is, and these things can be really important in studying and trying to learn about health disparities. The ATS group found that socioeconomic status is defined by a number of different variables. Education, occupation, marital status, health insurance coverage, a number of things, and that lower socioeconomic status has been linked to a higher incidence of health disparities with cardiovascular disease, I mentioned earlier, but probably with PAH as well. So this group emphasized that socioeconomic status should be studied, it should be looked at in research studies, not just whether someone's black or white perhaps, or what their age is, but more detail on socioeconomic status and focus on outcomes based on race, socioeconomic status, sex, gender identity, etc. So this committee also recommended that we should focus on educational resources to deal with these health disparities. That we should focus on a multidisciplinary approach that incorporates social workers, medical interpreters, things that could really help disadvantaged patients. Focus on environmental stressors. Focus on other unmet needs initiatives that don't often involve socioeconomically disadvantaged patients. So they also recommended partnering, getting groups together, organizations together, the PHA, the ACCP, the AHA, etc., getting groups together to focus more on these shortcomings, these health disparities that we should be able to deal with that clearly affect patients with pulmonary arterial hypertension. So I think the future, I hope, is bright once we start focusing more on this so that we can help those folks that are disadvantaged that have PAH. Well, I'd like to talk for a few minutes about how health disparities impact outcomes in PAH. And this is before COVID. So there's certainly conflicting data on the impact of race on pulmonary arterial hypertension. There's some data suggesting increased mortality in Asian and African patients that have PAH. There's a paper published in 2008 that reviewed vital statistics from 1994 to 1998, revealing that African Americans with PAH exhibited higher mortality rates, and they were substantially higher compared to white populations, and African American women had the highest mortality rates across all ages. So this is some data, and again, this is pre-COVID data, pretty old data. Does they still hold? I think there still are some health disparities and some differences that we need to deal with. So there's several nice reviews about PAH health disparities before COVID. One by Al-Namani and published in Pulmonary Circulation 2017 used a PAH biobank, and they looked at 34 PAH centers. They found that PAH patients were about 2.5 times, African American patients were about 2.5 times more likely to have a diagnosis of connective tissue disease associated PAH compared to non-Hispanic whites and Hispanics. Hispanics were twice as likely to have PAH associated with congenital heart disease compared to non-Hispanic whites. Hispanic patients with PAH were less likely to be treated with PAH-specific medications compared to non-Hispanic whites. So these are some things that were found that are clear disparities that clearly impact outcomes. Socioeconomic factors have included access to health care, access to health insurance. These data, though, have not been captured nearly as often in studies. So I think identifying these disparities in PAH patients is the first step towards eradicating them, but we do have some outcome data. Now, the REVEAL registry, a paper by Bedrick and colleagues, published in the Journal of Heart Transplant in about, it was last year, the year before, I think it was 2020, talked about the impact of race on survival in PAH and results of REVEAL. So they collected data on race, but they didn't collect data on socioeconomic status. There was no difference in mortality based on race or ethnicity, but there was inadequate access to care and probably inadequate quality of care based on some of these factors. So clearly, socioeconomic status needs to be studied, not just race. There's a big analysis. I think it was an important study. It was 3,000 patients in REVEAL registry, and there were about of those 3,000, about 390 some that were black, 200 and some that were Hispanic, about 100 or so Asian or Pacific Islander, and 88 that were listed as other. And again, I mentioned some of these differences that they found. So there clearly are health disparities and outcomes that are likely different. So we need more data. I think the answer here is there's certainly suggestions there's disparities, there's no doubt, and that they do impact outcomes. I think there's clear disparities, but in PAH patients of different socioeconomic status, race, etc. But I think that the actual outcomes are a little less clear. There's certainly hints that outcomes are different depending on socioeconomic status, race, etc. So we need a little more data, and we need to include this information in registries and research studies and things like this. We talked about health disparities in patients with PAH, and this is magnified greatly, I think, in the COVID era. So what are resources available for patients? Well, certainly the first one that comes to mind is the PAH. The PAH is an amazing organization. The Pulmonary Vascular Association has been ongoing now for decades. We've had meetings every other year for many years where we get patients together. I think one of the last meetings there was 1,000 patients. Didn't do it during the pandemic, of course. These patients come. We, those of us interested in pulmonary hypertension, give lectures to patients, to their families, to spouses about everything from diagnosing PH to different kinds of PH to what medications are used. We try to educate patients. So the PHA is a superb organization and has really emphasized the need to focus on patients during the pandemic and even on race and racial and socioeconomic disparities that occur in healthcare. So PHA is an amazing organization. Any patient can get on there and Google it. Again, based on health disparities, you may not have a laptop or you may not have a computer, but these resources are available. We want to ensure patients get good health care and good education about health care. So we want to make sure they can get reimbursed for what they need for pulmonary hypertension. Patients need echocardiograms, they need caths. Telemedicine has been a great resource for PH patients during COVID. We can do a pretty good job evaluating at least certainly stable patients during COVID by telemedicine. So that's, I think, a great resource for patients, and the vast majority of PH centers have telemedicine. Multidisciplinary care is really important. We have, for example, a superb rheumatologist at Cedars-Sinai, and when we have a connective tissues PH patient, our patients have got to see the rheumatologist. They do an amazing job with histories and figuring out and sorting out some of these complex connective tissue disease. So multidisciplinary care we've got to offer to our patients. One of the most important things, I think, is support groups for PAH, and this applies to COVID PH, to PH, and certainly there's support groups out there for COVID alone now that doesn't involve PH. But at our center at Cedars-Sinai, Wendy Hill, a nurse practitioner with 20-some years of experience in pulmonary hypertension, does an amazing job with our support groups. She does them on weekends on her own time. She doesn't get paid for this. She does this because she wants to do it. And I've given a number of lectures on PH and COVID, on PH medications to PH patients, COVID medications to PH patients. We've discussed vaccines for PH patients. Many patients are afraid to get a vaccine. We've learned now that the Pfizer vaccine and the Moderna vaccine are very safe. We need to make sure our patients have access. It's a really important resource for patients with PH, access to vaccines, so we can end this pandemic. Well, those are a few ideas about resources available to PH patients. Thank you.